Classification systems for the mandibular third molar impactions. Removal of the impacted teeth can be relatively straightforward or extremely difficult, even for the experienced surgeon. To determine the degree of difficulty preoperatively, the surgeon should methodically examine the clinical circumstances. The primary factor determining the difficulty of removal is accessibility. Accessibility is determined by the adjacent teeth or other structures impairing access, or the extraction delivery pathway. This includes assessing the ease of exposing the tooth and preparing a pathway for its delivery and preparing a purchase point. With careful classification of the impacted teeth using a variety of systems, the surgeon can approach the proposed surgery in a methodical fashion and predict whether any extraordinary surgical approaches will be necessary or if the patient will encounter certain post-operative problems. The majority of the the majority of the classification schemes are based on the analysis of a radiograph. The panoramic radiograph is the imaging of choice for planning removal of the impacted third molars. In some circumstances, a well-positioned periapical radiograph is adequate, as long as all parts of the impacted tooth are visible along the important adjacent anatomy. When the roots of a third, lower third molar appears very close to or superimpose over the inferior alveolar canal on a panoramic radiograph, a cone beam computed tomography may be useful. This imaging technique accurately shows the relationship of the roots to the canal. For each patient, the surgeon should carefully analyze the factors discussed in this section. By considering all of these factors, the dentist can assess the difficulty of the surgery and to elect to extract the impacted tooth that are within his or her skill level. However, for the patient's well-being and the dentist's peace of mind, the patient should be referred to a specialist if a tooth presents a difficult surgical situation or if the dentist cannot offer optimal intraoperative pain and anxiety control. Now, the most commonly used classification systems with respect to the treatment planning uses a determination of the angulation of the long axis of the impacted third molar with respect to the long axis of the adjacent second molar. Teeth at certain inclinations have ready-made pathways for removal, whereas pathways for teeth of other inclinations require the removal of substantial amounts of the bone and or tooth division or sectioning. This classification system provides an initial useful evaluation of the difficulty of extraction, but is not sufficient by itself to fully define the difficulty of molar removal. The impaction is generally acknowledged as the least difficult impaction to remove is the mesio-angular impaction, particularly when only partially erupted. You can see in the figure 10.6. This is the showing a mesio-angular impaction, which is the most common and the easiest impaction to remove. The picture B showing the mesio-angular impaction is usually is usually in proximity to the second molar. That is, it is inclined towards the second molar. Very important. The crown of the mesioangular impacted tooth is tilted toward the second molar in a mesial direction. This type of impaction is the most commonly seen and making up approximately 43% of all the impacted third molar, lower third molars. When the long axis of the third molar is perpendicular to the second molar, the impacted tooth is considered horizontal. You can see in the figure 10.7. This is the figure 10.7 showing the horizontal impaction, which is an uncommon and more difficult to remove impaction than a mesioangular impaction. In picture B, showing the occlusal surface of the horizontal impacted third molar is usually immediately adjacent to the root of the second molar, which often produces severe periodontal disease. This type of impaction is usually considered more difficult to remove compared with the mesioangular impaction. Horizontal impaction occurs less frequently, but seen in approximately 3% of all mandibular impaction. Now let's talk about the horizontal impaction, in which the long axis of the impacted third molar runs parallel to the long axis of the second molar. This impaction occurs with the second greatest frequency, accounting for approximately 38% of all lower third molar impactions, and is considered third in ease of removal. You can see in the figure 10.18. In figure 10.18 showing the vertical impaction, in which is the second most common impaction and the second most difficult to remove. The vertical impaction is frequently covered on its posterior aspect with the bone of the anterior ramus of the mandible. Anterior ramus of the mandible. That is anterior ramus of the mandible. Now, finally, the disto-angular impaction involves the tooth with the most difficult angulation for removal. You can see in the figure 10.19 showing the disto-angular impaction, which is an uncommon and the most difficult of the 4 types of the impactions to remove. The occlusal surface of the disto-angular impaction is usually embedded in the ramus of the mandible and requires surgical bone removal. Requires significant bone removal for extraction. In disto-angular impaction, the long axis of the third molar is distally or posteriorly angled away from the second molar. The impaction is the most difficult to remove because the tooth has withdrawal pathway that runs into the mandibular ramus, and its removal requires significant surgical intervention. Disto-angular impaction occurs uncommonly and account for only approximately 6% of all impacted third molars. Erupted third molars may also be in disto-angular position. When this occurs, these teeth are much more difficult to remove compared with other erupted teeth. The reason is that third molar's mesial root is very close to the roots of the second molar. In addition to the relationship between the angulation of the long axis of the second and the third molars, the teeth can be angled in buccal, lingual, or palatal directions. When approaching lower third molars, the possible presence of a high ridging lingual nerve still makes a buccal approach more appropriate even when the tooth is inclinated toward the lingual aspect. Rarely the transverse impaction occurs, that is, the tooth erupting in an absolutely horizontal position in the buccolingual direction. The occlusal surface of the tooth can face the buccal or lingual direction. To determine buccal or lingual version accurately, the dentist must take a perpendicular occlusal radiograph or obtain a CBCT. However, this determination is usually not necessary because the surgeon can make this identification easily in the operation, and the buccal or lingual position of the tooth does not greatly influence the approach to the surgery.